research programme in Leeds in the confines of a very, very busy neonatal unit, which is a challenge. And then I help Adam Glazer with research in the Children's Hospital. And then I've got this separate role, which is trying to bring together research, paediatric research across the unit. And I guess I'm trying to be, and I'm trying to tell you guys and encourage you guys that, you know, research isn't just for academics. You can be a clinician and you can be research active, you know, and recruiting to studies and not be an academic, but be a clinical active researcher. And we're actually only discussing it the other day that actually for babies, certainly in neonates, if you are in a trial, you do better. And it actually doesn't matter which arm you're in of the trial. So even if you're in the control arm, you do better because everything's so much tighter and much more protocolized. So actually being in a study, regardless of what arm you're in, for babies means you get better outcomes, and trust that are research active get better outcomes. So, you know, whatever your future is and whatever your plans are, just I think there's this thing that puts research with academia, and then not necessarily. You can be a very research active clinician. And the other thing, I suppose, about what Diane was saying is, I think one of the amazing things about medicine is you can just do so much other interesting stuff. Once you get your consultant job, just always be an eye out. It doesn't have to be research. You know, I do stuff with the National Screening Committee, I do this role with the Congenital Anomalies Registry. There's always interesting intellectual stimulation out there if you want it and are prepared to go looking for it. So they're kind of my two pieces of advice, research advice. Right, is that still there? I'm trying to find that thing.
We currently can see your screen looking at MS Teams.
Oh, okay. For goodness sake, I was trying to, can you see it now? No, it's stopped sharing, hasn't it? Something's going very funny with that. Right, let me start again. Share screen. This is going funny. Ugh, I get so annoyed with people that have IT issues. I mean, how long have we had Teams? How long? Try again. I don't know if it's something with my entire screen. Let's try that one. And we go back. I wanted to try and get that one up where I can actually see you. Is that come up? Associate PI scheme? Yeah, is that there? Just shout if it stops. So that, I mean, I've ended up, because I had to write these slides quickly, just kind of like put a few bits in. But remember the Associate PI scheme, Yorkshire and Humber are actually the children's across the country. Yorkshire and Humber actually have the most number of Associate PIs on trials than anywhere else in the country in paediatrics, and that's fantastic. And most of the studies you'll see in whichever specialty, general peds, neonates that are coming through will be registered for the Associate PI scheme or are registerable. And basically it's a way of you getting some research experience and me or whoever the PI is getting somebody to champion that study. And it's like it's not a huge amount of work, but it's a bit of extra work, but you get signed off and you're affiliated with an official scheme. And I think it would look nice on any form of application for anything you're doing, building on your registrar training. So I don't know, Diane, I don't know how the Comet study came up, but this is a little study, a big study, so a big national study looking at whether we should cool babies with mild hypoxic ischemic encephalopathy. So we cool all the babies with moderate and severe hypoxic ischemic encephalopathy, and we're all happy with it and we all think it's safe. And so I guess the natural progression is to think about whether we cool babies with mild encephalopathy. And although it's safe and we don't know any sort of measurable harms in terms of physical harms, but you've got to remember these babies are not, you know, they can't breastfeed, they don't have much skin to skin, they might have to be moved between hospitals. So there may be sort of more difficult to measure harms. So we do need to know, even in mild encephalopathy, that it's doing good. And that, when that came through, so as the regional research lead, I get various information about various studies through from various sources and sort of then try and send them to the right people. And this came through, and it was one that we were sort of thinking, maybe this is something we should be running as a network, and there may be gaps in some hospitals and not in others, and let's look at how maybe we can work as a network together within neonates or pediatrics, whatever the study, to deliver a study on a network level rather than an individual hospital level. And then that got, so we'll come back to that, but that just then got me thinking about cooling studies and other studies we might do, and I got on a bit of a tangent, but anyway, I think it's quite an interesting tangent. So we know that we cool. That was the Toby study. It's probably been one of the big changes to neonatal medicine in the last 10, I'm trying to remember, so I was 20, actually I'm not going to say how long ago it was, but I was at St George's in London as a new grid trainee when this study was going on, and that was actually a quarter of a century ago, so let's not dwell on that. But anyway, so we know that's a big change. We all do it. We know what we should be doing. It would be not appropriate not to cool a baby that fits criteria. But then you end up with all these other research questions. So you end up with, well, how quick should you cool? You know, I mean, we do it as soon as possible, don't we? But we haven't shown that cooling straight away is better than within 6 hours. There's now guidance that says actually you shouldn't passively cool in delivery suite until you've done a full assessment. So there's a slight pullback there. How is 33 degrees the right temperature? Feels about right. Maybe we should go colder. Maybe 34 would be all right. What about 36 weeks? What's the appropriate cutoff? Could we safely cool 34, 35 weekers? And that's a really interesting question, because at what point does being cold become harmful? So we know that at 24 weeks, being cold is an independent risk factor for mortality. At 37 weeks, it's good for your brain. So it flips somewhere. How long do you cool? Is 72 hours right? And again, should we cool babies with mild HIE, which has then come through as this Comet study that we'll talk about. But then other questions, how do you rewarm? And what about these babies that collapse on the postnatal ward that we see sometimes? You know, often by exclusion, there may be an accidental overlay or something, but should we cool those ones as well? A 3-day-old baby who's had a hypoxic ischemic insult as a result of that, should we cool them? So there's loads of interesting research questions that need answering, and maybe single site studies are not the way forward. So because what we've got to remember is that I'm going to put that on big screen so you don't see that click to add title. Half the babies still have a poor outcome. You need to cool 8 babies to have 1 improved outcome, and so we still could do better, isn't it? So there's still, not only are there lots of research questions, it's the other question is, well, is there things we could add to cooling that are going to be more beneficial? Experimental therapies, whatever you want to call them, I call it cooling plus. Or the other thing, the first one, precision medicine. So if we can identify the right babies that would benefit from cooling, then that would be good as well. So we would pick and choose the right babies to do that. And some of the things that have been tried, we've tried xenon gas, melatonin, cannabinoids, topiramate, and erythropoietin over the last few years have been choices of the cooling plus. And interestingly, the same, so the Comet study, the Genie study, and the erythropoietin study are all from the same brain research group, neonatal brain research group from Imperial in London. So erythropoietin's come full circle, and they're trying to do that trial again. The Genie study was an interesting one. So that was looking at, and again would have been done well to be run on a network level, because the babies really, they needed blood within 6 hours of birth. So you can imagine it would be useful to have referring hospitals, and you've got to remember, if you're going to run a study regionally, embrace on board. And that was looking at copy number variants and your genetic makeup, essentially, to see if different babies respond to different ways of cooling. So loads of research options there, even out with cooling for mild HIE, which is probably a quicker win than some of these. So, and this is the reason, I'm not going to go through this in any detail, but this is kind of the reason why there's lots of different places and lots of different medications that you could use and think about using. So because you've got all these different injury mechanisms, and it like drug repurposing is a real big thing at the moment, and you can get these artificial intelligence programs that say, oh, I want a drug that mechanism is X, Y, or Z related to all these chemical effects of a hypoxic ischemic injury, and it will spit out potentially drugs that work in that way that might help. And that's, I think, where people have come with topiramate, erythropoietin, those sorts of things. Quite a few small studies that have come through. So we've tried cannabidiol, I can never say that, CBD. That's been tried as an add-on. You know, that seems to be reasonably and sensibly a sort of brain protective medication. All these medications will have gone through all the right sort of ethical processes before they've got to clinical trials. So cannabidiol was looked at. Genie, the other one I was just going to whiz through these, was this one looking at gene expression with brain injury, both, and looking at neurodisability to see if different genetic people, different epigenetics respond differently. And perhaps then you could pick and choose which the right babies to cool were. And then you can justify, in mild HIE, for example, moving a baby away from its family from one hospital to the other to be cooled, because you know that baby has the right genetic expression that means that they're more at risk. So this sort of precision medicine is really, really useful. This study has finished, but obviously there's a big lag then before you get the information from neurodevelopment at 18 to 24 months. And what I thought this was great, this is what the team were trying to do. They wanted a point of care test for disease stratification in neonatal encephalopathy. Yeah, I mean, it's a big statement, what that second statement, but it will. So they're saying we'll do a point of care test and we will know which babies need to be cooled. And so perhaps in these groups where mild HIE, where it's not as clear cut, then you will pick based on this. So we'll have precision medicine, and then we'll have cooling plus as well. So this was just what I was saying before about making sure that all these trials will have gone through the correct phases, you know, your preclinical phase, and it's when you get to phase 3, they're the ones that are tested, is the wrong word, but people are not just going out there and picking a medicine and thinking, oh, let's try that. They're actually thinking it's going through due process, and these are repurposed medicines, potentially some of these. So Xenon is another one that they've looked at, trying to improve outcomes, and this was one of the first studies after Toby that they did as an add-on. So it was using xenon gas, which is sitting there, as you'll all remember, in the periodic table. Sorry, this is because I've made, just ignore that big black line. So they started with a proof of concept study, and so they had hypothermia and inhaled xenon, and they knew that xenon had effects on biochemical activity in the brain, preservation of the cerebral structures, and they hypothesized as a result of that would improve outcomes at discharge. What this does, it's a glutamate receptor inhibitor, and if you go back to that picture, like I was saying, there's lots of options to make a difference. Of, you know, you can see it down on that left hand column, you've got your NMDA receptor hyperexcitability. So that's, you know, that's where they know physiologically the xenon will have an effect. And so sensible, gone through, you know, you go through those correct processes and you go to a phase 3 study, and you start with a pilot study, working out, and that's what they've done with Comet as well, that we'll talk about, working out, you know, is this feasible? Will people say yes to it? Can we actually deliver it? Before then going on to a bigger trial. And what they did with their little trial, that was way back now, so nearly 10 years ago now, they recruited 92 babies, and they did cooling or cooling plus xenon, and they found that they could do it. So in the pilot told them it was feasible and safe, but it didn't seem to enhance the effects of cooling. So that was xenon sort of off the list. The other thing that people have looked at as your cooling plus, or you're getting better at cooling the right babies, melatonin's been looked at. again through the correct processes, started in animal studies. So that comes from the pineal gland, and it's antioxidant neuromodulatory. So again, you know, not an unreasonable choice. And we know in animals it's neuroprotective, but it is delivered in ethanol. And so obviously you've got to think about these sorts of things, particularly in neonatal trials and the risks of toxicity. And the animal studies, this is all quite interesting in terms of seeing how a trial gets to the point where Comet is. So the animal work would say it would not be unreasonable to do a clinical trial. And I went back and I've looked at this again recently. So there was one study when I originally was thinking about this. This was about 5 years ago. When I've looked in the last year, there hasn't been any more. So there was one small study. You're talking tiny, tiny numbers here. And again, just to look at the pilot, is it feasible? Is it possible? And they did find some improvements, but actually you're talking about very, very small numbers. But interestingly, nothing has then happened with this. So you know, when you go through the literature, something's been tried. I don't know if there's more gone on that is not published. And this is one of the problems is with publication bias, and you only find positive publications. All the negative studies perhaps that have looked at melatonin, which is an important thing to know they're negative, aren't then published. So the publication bias can sort of muddy the water. So then there's cannabidiol, I know, cannabinoids, let's call them just kind of, and so it's these precursors that don't have the THC effects. So we had been approached about 6 years ago from a pharma company looking at a cannabinoid study, which would probably be reasonable to add to cooling to see if it helps, which has not made any progress since. And these things can go quiet for years and years and years. Again, there are some animal papers in the literature. So if a pharma company came back to us in the region and said, would we consider a study adding cannabinoids? I think we would seriously consider it. Topiramate, again, people have thought, as I've said, an example of drug repurposing, looking at how it works and thinking actually this might work for brain protection. And that again, they've done as you can see, there's lots and lots of small pilot studies, but nothing that's then taken things forward. And erythropoietin was the other thing, and that's, as it said, that's come around full circle. So it's now going to be a proper clinical trial looking at erythropoietin in as an adjunct. So there was this phase 2 trial in 2016, and which said it may improve outcomes. And like I say, the team doing Comet are also doing an erythropoietin trial. I'm not sure how they're planning to do all these trials on the same set of babies, which will be interesting to see. So you've got one set of babies with hypothermia. I suppose what they'll do is they will do Comet on the mild HIE, which is their question, and then this will be for the established babies that we know fit into cooling. So you can have lots of things going on at one time. So we'll get back to Comet. That was a bit of a ramble. So yeah, so it's one of the big changes. Like I said, it was 25, I think 24, yeah, maybe actually it's less than a quarter of a century, it's not that long, 20 years, let's say. But still babies, a lot of babies will have a poor outcome. And so precision medicine and additional pharmacotherapy may well be the way forward. We've got no wonder drug, and actually at the end of the day, we could do with preventing HIE. And, you know, there are obstetric, measuring kicks and things it is really important to stop these babies having HIE in the first place. But anyway, so that's a bit of a ramble through HIE research. So Comet wants to know if cooling these babies with mild HIE improves outcome. So that, and going back to this diagram and thinking about how this would work regionally. So these babies are going to be born in all neonatal units, aren't they? They're going to be born in level 1, level 2, level 3 units. And it'll be the level 1 and the level 2 units that will need to send their babies in. So we wouldn't plan to cool anywhere else than we already are. So that would be the 4 tertiary units that would be cooling. So already you're going to have to ask yourself, and these are some of the questions that have come up, the practicalities are, so we need some baseline data in the region to know how many more babies would we have to move. because Embrace would have to move them. How many babies are there with mild HIE in the region? And then think, right, well, X number would consent. So how many more would we have to move? Would Embrace need extra cooling mattresses if they were moving more babies? If we're moving more babies to be cooled, do the tertiary level NICUs need to have more capacity to bring them in? So there's, you know, you start even with the very beginning, and whilst regional working will, I think this is right for giving it a go, there's lots of questions that we need to answer. So yeah, so there's a capacity issue. So we're waiting at the moment for some basic data from Badger to tell us across Yorkshire and Humber how many babies with mild HIE were admitted to neonatal units. And then we can start thinking about, okay, so say 50% of them consent, how many would we be moving in a year that we aren't moving now? And Embrace have got, say, 2 cooling mattresses, would they need another one? So there's lots of things, and you need to really work this through, because actually you need to then go back to the study team and say, perhaps, yes, we can do this, but Embrace will need to move more babies and will need to have another cooling mattress. So you will need to pay for the cooling mattress. So you have to get your feasibility right. I mean, it's hard enough feasibility on a single site. And Andre, I think just during the call, if you think about what we were talking about on Monday about the base trial, that's just within one unit, working out how and what, when and how. And this is talking about trying to do it regional wide, but because these babies are going to be moving a lot, it would seem reasonable to do it regionally. Again, just to flag up with the follow-up period, you've got quite a lag. So if this trial was recruiting for 2.5 years, it started at the beginning of this year, you've got then till the end of, say, 2026, and then that last baby needs to have their 2-year follow-up. So this shows you how the lags from, because two-year follow-up is the sort of the standard of care for follow-up, and rightly so in terms of trial outcomes. It's a big lag. So you've got 4 years, potentially 4.5 years between recruiting the first baby and doing a 2-year assessment in the last baby. So actually, just on the subject of 2-year assessment, you've got to have somewhere to do them. So who would do the 2-year assessment? So they wanted Baileys for this. So would the babies come back to the tertiary units where they were cooled for a Baileys? Could they just go locally? Should the study team provide a Baileys person to come to the family's home? So lots of issues. That's for the study team to work out about who, what, where and when does this 2-year follow-up. So they're going gold standard. They're going a standardized Baileys assessment. Other studies, like the base study that we're talking about on Monday in Leeds, they're using parental questionnaire as their follow-up sort of measure. Now, there are some validated parental questionnaires in terms of motor outcomes and communication. Parker R, you might have heard of, and they are cheap, but they're probably not as effective or sensitive or specific as a Baileys. So Baileys cost more money because it's labour intensive, but parental questionnaires are cheaper and probably gives you a more broad brush stroke of follow-up. I mean, a trial purist, I guess, would want a Baileys. So anyway, so they want 426 babies across the country, and they want to run it on across 5 ODNs. So Yorkshire and Humber have been approached, and we're, as I say, in the process of working up and looking at how it would work. And there's kind of almost a pilot study within the study, in that the Thames where Imperial's based, whatever that's called, Thames Neonatal Network or something, they've started in the last month or so. So actually it's quite handy for us to sort of think about how we might do it at the same time as waiting for another network to sort of iron out almost the feasibility and that sort of thing. So it's not actually a pilot, but for us in Yorkshire and Humber, it is a pilot. Let me just go and shut my window because there's a stupid dog. So yeah, so the primary outcome, as in many of these, well, all the cooling trials should be composite score. So your Bailey's composite score at 24 months. Some of those pharma trials I told you about, they might use a sort of short-term, try and find a short-term biomarker for outcome, but not actual physical outcomes. So there's some fancy MRI techniques you can use to sort of perhaps measure brain injury as a more short term, so you're not waiting for your 4.5 years. So how do you get into this study? So I'm sure you, whoever's listening, you've done neonates. So mild HIE is so your A criteria, your cord pH, your basic SESI, your APGARs, or a continuous resuscitation at 10 minutes of age are pretty much, although not the same as your inclusion criteria for standard cooling. And then what you need is mild encephalopathy on your staging. And what's going to be really good about this study, if we can do it, which is kind of what goes back to that thing about babies do better if they're in a trial, regardless of what arm they're in. If you look at, I haven't got a pointer, but if you look the second box in neurological examination and AEG with that little video thing, I think it is on top, all doctors that might be seeing these babies, that would be all trainees and all consultants, ANMPs, I guess, across the region will have need to do the virtual neurological assessment training so that we're all doing a standardized assessment. And to my mind, that's tricky. But if you're talking about a 20-minute video, that's fantastic for just education and learning. So by being involved in the trial, that, to my mind, that's a massive knock-on positive. And because it's a virtual video that you watch, then it is, I think, realistically deliverable. But, you know, that to my mind, what's not to like about everybody having a 20-minute standardized neurological assessment? So your baby would come. So we're not trying to look at a different group. We're looking at exact same group. So over 36 weeks, exact same group as the standard cooling. So admitted with birth depression or whichever the phrase you're going to have your neurological examination by whoever's admitting you, who's done the video training, and an EEG. And if you're diagnosed with mild encephalopathy, then you'll be randomized. And so obviously you will need everybody to have had a CFAM. Do you know what? Which hasn't occurred to me until now. That's going to be another thing, isn't it? So we are going to need to be sure that all units have a CFAM, which may not be deliverable. And that's another thing, just, you know, talking through it. If a trial is not, if we as a network don't think we can deliver this trial, then we shouldn't do it. We should focus our energy on network, pediatric, you know, research network supporting a different trial that will work. So we can't have enough cooling mattresses, have enough transport capacity, have enough CFAM machines, then we shouldn't do the trial, and that's called feasibility, and that's really, really important. Anyway, so diagnose a baby with mild encephalopathy, you randomize them to normothermia or hypothermia, and you have your 2-year assessment. So just let me, what's the other one? Yeah, that was just that in a bit more detail. But so that's, and I'll take the slides off in a second. We can talk about it a bit more as a networker, because I'd be interested to know what you think. So yeah, so just looking a bit more. So you're born 36 weeks, you require resuscitation and you require admission. So this is not mild HIE, where say you've seen a cord pH of 6.9 and the baby's, yeah, they're all right, so they can go to mum for a bit. So then you do your video recording. Yeah, you record yourself doing the neuro examination. And then if they're normal, you exclude. If they're abnormal, then you go down these routes. And now I'm really disturbed about the fact that I hadn't noticed until now they all need an EEG. And I'm going to write that down so I can email the trial team. I think they said they don't, but anyway, it's more about the virtual examination. Sometimes what you find, you see, is Thames Imperial Network will say, oh yeah, because all the hospitals in London do have CFAM. So that's the other thing, different networks work in different ways. In our network, as far as I understand, and correct me if I'm wrong, not all units, and certainly not special cares, will have CFAMs. I think like Pinderfields, Calderdale, that sort of thing, I think would have a CFAM machine. So that just needs to be bearing in mind, because if we're going to do this as a network, then all the units in the network, and that would be the special cares such as Scarborough and Harrogate, the, you know, Pinderfields, Calderdale size, and the tertiary units should be doing. So that's that. Right, sorry. So yeah, so what's the plan? Nothing's ever so simple. And actually, so yeah, we're having at the moment we're having discussions around the NIC using capacity. So we're looking at getting somebody on Badger, to one of the data people, to look at how many mild HIEs. And this is why the other thing is getting the diagnosis right on Badger is so important, because actually we're using Badger for things like this, and sometimes I think just sort of put the first thing that comes into their heads in terms of the diagnosis, HIE or encephalopathy. So, you know, we are using this data for lots of reasons, so it's important that it's accurate. We need to talk to Embrace and work out, once we know how many babies there are, have they got capacity for this? Are they bought into this study? Do they want to take part? Because they're going to be a key player. Looking at capacity, I've said, and equipment. And actually, when I said equipment there, I meant cooling mattresses. But actually, we need to think about CFAMs as well. And then, like I say, we're going to watch, see how that Thames network get on, and see, you know, if they've had to modify at all what they do. But bearing in mind that actually different networks often work in different ways, and some networks only have one tertiary unit, so others have more. You know, it's all, some networks may have non-tertiary units cooling babies. So whilst we need to watch what the Thames are doing, we may have a different way of working. And then the other thing that's interesting, so that you get a recruitment target. So when you do a study, you say how many so a study, when they're approaching you, will ask you how many babies you think you're going to recruit, and that's your recruitment target. And accrual is, if you recruit a baby, you get an accrual, that's a number. And that then influences how your research department is subsequently funded. So it's a bit frustrating, but research, you know, recruiting to trials can often be a bit of a numbers game. So you don't want to under recruit, because that doesn't look good in terms of your research profile. But also you want to get as many babies in as possible to studies to then get you funding for the next year. So if we're running this as a network, who's getting those accruals? So there's lots of, I mean, there are plans to sort of try and move away from this number-driven research, because actually, if you can imagine, if you are offered to do, you get one accrual for a complex oncology study and 3,000 accruals for a really good, really quick and easy questionnaire study, the worry with this system is that you're going to do the quick and easy studies, because then you get your numbers and then you get your funding. So things are moving away from accruals, you know, hospital-based accruals. But at the moment, we would have to work a way of deciding who gets the acknowledgement, I suppose, for these babies coming in, and where does Embrace come into that? Because if Embrace didn't move them, we wouldn't get them. So I got lots of, I feel like I've got, not as a conflict, but I feel like I can see this from the leads, you know, role and cooling, and as a neonatologist, and also in that regional role, where I think I feel very strongly that I should be encouraging all units to be able to take part, all hospitals, all departments to be able to take part in research, and looking at the trials that are coming through. There's some really nice ped/general ped studies coming through, looking at whether babies less than 1 year old should have IV antibiotics for UTI, maybe oral's okay, and the length of course. So maybe actually for us, that's a better use of our regional research and, you know, regional research resource than doing this study. Or, you know, I want something that's gonna involve everyone together. And I do think, because these babies are born in all hospitals, that actually there is the potential there to be able to work really nicely as a network and support all the hospitals in the network. But we have to be sure it's the right study. And that was just, I was just flagging, actually, Diane, you've already flagged this. So you've got your regional, the BRIDGE work, which presumably is feeding into the trainee research network, isn't it? And then for any of you that are interested in neonates, they have a really nice research group called NeoTrips. There's a lot of QI work, national QI work in there, but a lot of it is answering new questions, so could be seen as research. So if you're neonatally minded, have a look at NeoTrips. It's listed in that RCPCH trainee research network. And there's lots of other specialty ones as well. So it's really great that you guys are feeding into the sort of national system. And I guess we need to find a way to get any of the local research groups, if there's trainees, I don't know if there's a group in any of the hospitals you guys are working in that could then feed into the BRIDGE, and then that then feeds into things nationally. So that was a very rapidly put together presentation, because I'd lost everything. I don't know where people are working and what they think about how that might work from. So Andre's in Leeds. I don't know where are other people. Is anybody working in a smaller DGH that thinks actually, yeah, that would be nice to be involved in something like that, that we could all join in. Where are you now, Diane?
I'm out of programs. I'm working from home.
Oh,
I'm
nice.
going back to community in August. So
okay,
yeah.
okay. I'll stop sharing. Yeah. So I think there's real. Oh, there's Manna and Caroline Britton. I think there is a real chance here to work all of us together, but there are a lot of practicalities to iron out. And the idea sounds nice, doesn't it? That the whole network gets to be involved. The tertiary units can support the smaller units. Everybody gets trained on a neurological assessment, which has got to be good. All these really, really good things, but you have to get your feasibility right, because what you don't want to do is you don't want to say, right, we're going to take part in this study and then not deliver, which is what we've got in Leeds at the moment with Surfon, a little bit in that we've taken part, we probably didn't get the feasibility right, and then we're underperforming, which is not good for reputation. It's not good for the study, it's not good for reputation, not good for lots of reasons. So I think if we can iron out some of the issues with this, I think it would be a really good thing to take part in. I think the research question, should we cool babies with mild encephalopathy, feels like the natural progression of cooling, and a lot more straightforward than cooling plus whatever medicines, repurposed medicines may be out there. And actually they can happen alongside, like I say, because the trial team that are running Comet are running the erythropoietin study as well, but they're a different group of babies, really. Any questions? It was a bit short.
Yes, please, I have a question.
Yeah.
I think on the slide I noticed you have to send a video recording of a neurological examination, and I'm just wondering how comfortable or how easy it is to get someone else to, like on a night shift, to go to.
When they came and spoke to us and did their slides, they didn't mention that. So yeah, how are you actually physically gonna, I don't know if you video the baby, video yourself doing it. So that was slightly glossed over in their presentation to us at the end of the year. So that's something, again, that's about getting your feasibility right. And we made up this thing a few years back where we were doing research simulation, but actually it's a really good idea, because actually then you can say, right, this baby's come into my unit in Airedale with mild cooling. Let's walk through with a doll what we actually would need to do, and then that's where you unpick some of these things like that. So yeah, we need to be clear, don't we? And I don't know the answer. What do you mean by a video? Who's being videoed? How you're being videoed? Does that need a second pair of hands? Because if you're on your own trying to admit this baby in a baby unit, confidentiality, those sorts of things, absolutely. So that needs looking at, and this is why I think research simulation we should do more, because actually I've flagged up a couple of things. We've had a lot of discussions with Comet. I've flagged up a couple of things just by talking to you, think about, oh yeah, we need to be sure about that, and we need to be sure about that. So yeah, we need to look at that. So confidentiality, practicalities, what is it they want videoing, or do they just want a video of the baby? In which case that would have to form part of your consent, wouldn't it? For the family. Neil. Oh, he's gone on. I think he's going to say something now.
I think Andrea had some previous questions. Andrea.
Can you hear me now?
Yeah.
Yes.
Oh, great. What were my questions? You know, in Comet, we often have that kind of struggle anyway with cooling babies that are quite sick about. You've got that paradoxical effect where you cool a baby, they become a bit cardiac unstable or can do, and if they are needing inotropic support, at what point do you, like if you're having to uncool them or warm them back up, would you pull them out of the study and then would you follow them up and take all that data?
I think they would be intention to treat, so I would have thought that they would stay in the study, because that's an important, you'd hope these mild ones wouldn't be needing treatment, but it's an important group that might come out the study. So I would have thought you would follow them up as per their group.
Yeah, I suppose that's a typical subset of patients you might encounter anyway, mightn't you? That they just have poor from birth, and then they do have those.
And it's a bit like, for those of you that, as a practical example, have done the Feed 1 study. So if a 30-week baby gets randomized to have full feeds, and then they are given full feeds, and then we have to stop them because they won't tolerate them. That is absolutely key, important information, isn't it, to the study? So then they stay in the study. And the fact, if you find out that actually all those 30-weekers that were randomized to full feeds then all had to stop their feeds, then you've got part of the answer. But you wouldn't know that if they then all came out the study. So I will check, but I would imagine stay in and follow them up as per the other ones.
I'm kind of greedy because I had 2 questions.
Yeah, you can.
I'm sorry, Diane. I'm sorry, Brina. I'm sorry, Neil, and anyone else.
You're not that sorry though, really, are you, Andre?
I'm not sorry.
No.
I am sorry. Sorry if you've already answered this. I lost connection when you were talking about it, but with regards to Genie and the gene expression,
yeah,
who's the control